Most people assume blood type only matters for emergency transfusions, or that debunked diet book from the 90s. To be clear, the clinical data confirms that specific diet is nonsense, but the noise from that fad buried a much more compelling reality. Your ABO blood type is quietly influencing your cardiovascular risk, your cancer odds, and your gut biology right now. Yet almost no one factors this into their preventive protocol. We are going to go through what the peer-reviewed literature actually shows regarding these effect sizes and where this should shift your monitoring focus. The biology here is measurable and significant, even if the old diet recommendations were not. The clearest signal in the ABO literature involves cardiovascular health, and it specifically comes down to two clotting proteins called von Willebrand factor and factor VIII. If you have a non-O blood type, meaning AB or AB, you carry consistently higher baseline levels of both proteins compared to type O individuals. This isn't a lifestyle variable you can change with a better morning routine, because it is baked into the biochemistry of how your ABO antigens interact with your blood vessel lining. Higher levels of these proteins create a prothrombotic baseline state where your blood is essentially primed to clot more readily than average. While that might seem like a minor detail on a single lab report, that difference compounds over the course of a lifetime. When researchers looked at a massive genetic study using UK Biobank data, they found that blood groups A and B showed significantly higher odds of thromboembolic events compared to type O. These odds ratios reached as high as 1.56 in some comparisons, and the data also showed elevated risks for atherosclerosis and heart attacks. A separate association study reinforced these findings by showing that the O antigen correlates with lower total and LDL cholesterol. If you are type A, your lipid baseline is structurally less favorable from the start, and that has nothing to do with your diet and everything to do with your glycan chemistry. This is where the exercise data gets interesting for anyone following a high-performance protocol. One study measuring how these proteins respond to physical exertion found that type O individuals show a much lower spike in von Willebrand factor after a workout than non-O types. Intense training acts as a stressor that activates your coagulation system. So if you are non-O, that activation lands on top of an already elevated baseline. Your cardiovascular stress response to a hard run is simply not the same as a type O athlete doing the exact same workout. If you are AB or AB, you should probably be running your cardiovascular monitoring at a higher frequency than the standard guidelines suggest. You should check your lipid panels more often and try to include von Willebrand factor and factor VIII in your blood work if your doctor can order them. Your health outcome isn't fixed, but your starting position is further from zero, and you cannot close that gap if you choose to ignore it. The cardiovascular data gives us the most consistent look at these risks, but the cancer literature adds a second layer that becomes hard to ignore once you've actually seen the numbers. Pancreatic and gastric cancers show the two strongest associations in the research. When you look at pancreatic cancer, multiple pooled analyses show that non-O blood types carry a relative risk about 20 to 30% higher than type O individuals. Group A usually lands with an odds ratio between 1.2 and 1.3, while Group B tends to sit slightly higher. This is one of the most reproducible ABO findings in the medical literature because it holds up across large prospective cohort data, which is exactly where most other cancer associations usually fall apart. Gastric cancer follows a very similar pattern. Type A has shown a consistent link to elevated risk for decades, and meta-analytic pooling puts the odds ratio right around 1.1 to 1.2. The mechanism here connects back to H. Pylori, which is the bacterium responsible for most gastric ulcers and a primary driver of stomach cancer. ABO antigens actually change how H. pylori sticks to and colonizes the stomach lining, and certain strains prefer to bind to specific glycan structures. If you are type A, that interaction is less favorable for your long-term health. When you add the elevated clotting factors that link to tumor progression pathways, a very coherent biological story starts to emerge underneath the raw data. The signal for breast and lung cancer is much weaker by comparison. Some meta-analyses report a 10 to 18% increased risk for type A compared to type O, but prospective cohort studies usually fail to replicate those findings. Case control designs are much more vulnerable to selection bias, and that is where the majority of these positive findings for breast and lung cancer come from. It is worth tracking the data, but it isn't a reason for alarm. The finding regarding AB-type cognitive impairment is the weakest signal in this entire report, though it is worth mentioning if you care about longevity. One broad review found that AB individuals might be more susceptible to cognitive decline, especially when they have a higher burden of cardiometabolic issues. We don't have precise hazard ratios yet, and the causal pathway isn't fully established. But the overlap with the cardiovascular data we already discussed is consistent. You have to calibrate your perspective on all of this, because these effect sizes sit in the 1.1 to 1.3 range. Your blood type is a modifier rather than a final sentence. Smoking, your daily diet, H. pylori infection history, and your family genetics are still going to dominate your individual risk profile. What your ABO type gives you is a baseline to work from, and it might be a reason to weight certain screening protocols differently before any symptoms actually appear. The data on cardiovascular health and cancer both work through mechanisms that feel familiar, like clotting factors, or how pathogens stick to cells. The gut layer is much less intuitive, and it hasn't received nearly as much attention in the clinical conversations around ABO biology. To understand this, you have to realize that your ABO antigens aren't just stuck to your red blood cells. They are expressed on the surfaces lining your gut, and the glycan structures they create act as both landing pads and food sources for your bacteria. Certain species bind to these structures directly, while others use enzymes to eat them. This means your blood type is a physical part of the soil that your microbiome grows on. A genome-wide association study of about 9,000 people identified 38 genetic locations linked to the makeup of the gut microbiome. The ABO location and the FUT2 secretor gene, which decides if your antigens actually show up on your mucosal surfaces, were among the most consistent signals found across different groups. This is a significant data set, and the fact that the results were replicated across independent cohorts makes the findings much more reliable. The specific pattern for non-O types who are also secretors is a higher amount of certain Bacteroides species. If you are type A or AB, there is an even more specific finding, where these individuals show more microbial genes for utilizing GalNAc in their gut. GalNAc is the sugar group that defines the A antigen, so bacteria that can eat it have a massive structural advantage in your gut, because their food is always available. One of the main beneficiaries of this environment is Faecalibacterium prausnitzii, which is a species that produces butyrate and has well-documented anti-inflammatory effects. Having more of this bacteria is consistently linked to better gut barrier function and lower overall inflammation. That sounds like a clear win for A and AB types, but the full picture isn't always favorable. Secretors also show a lower amount of Blaudia and an increase in Clostridialis taxa. Since Blaudia is linked to healthy metabolic signaling, its reduction acts as a counterweight to the benefits of the other species. The microbiome effects of your blood type aren't moving in one single direction, but instead they shift the community in ways that have mixed results for your health. The honest truth is that your diet, your history with antibiotics, and your lifestyle explain far more of your microbiome variance than your blood type ever will. ABO is a background condition rather than a dominant controller of your gut health. The same genotype can produce completely different microbial communities depending on what you feed them and what drugs have disrupted the environment. This area of research is worth watching as scientists look into prebiotics and probiotics tailored to your secretor status. Most commercial products claiming to do this today are way ahead of the actual data, but the logic of matching supplements to your genetic profile is grounded in real biology. So what do you actually do with this information? Your blood type isn't a destiny, but you should think of it as a prior or a set of baseline risk adjustments that shift where you focus your monitoring. While the biological mechanisms are real, the effect sizes remain modest, which means the real leverage comes from acting on these signals before any symptoms actually appear. If you are non-O, your cardiovascular protocol needs to run more aggressively than the average person. You should consider more frequent lipid panels and ask for VWF and factor VIII tests to get a clearer picture of your specific coagulation risks. Type A individuals need to keep H. pylori testing on their radar if they feel symptomatic, and they should weave pancreatic and gastric cancer screenings into their medical conversations much earlier than the standard guidelines suggest. For those with type AB, the cardiometabolic burden is your clearest signal, which makes managing your blood pressure and metabolic markers more important than ever. None of this suggests you should abandon standard preventive medicine. Instead, you are layering these fixed biological variables into the health protocol you are already running. This is what personalized prevention actually looks like in practice. Because you aren't waiting for a diagnosis to change your behavior, you are simply adjusting your baseline monitoring to match your baseline biology. Have you enjoyed this video? Let us know by pressing the like and subscribe buttons.